Right, I think we'll be good to start. So good morning, everyone. Thanks for joining us in a special joint session today. I think it's the first time that we're able to combine rounds between the Department of Pediatrics, Surgery at CHEO, as well as the OB-GYN at the TOH. So a lot of people should be joining as we get started. I'd like first to begin by acknowledging that we're gathered today on the traditional and ceded territory of the Algonquin Anishinaabe people. And today it is my absolute pleasure to introduce our speaker, Olivia Frias. She's joining us from Cincinnati Children's Hospital. So this is the first of 4 lectures scheduled this week during the Canadian Fertility Awareness Week. So Olivia received her bachelor degree of science in nursing from the University of Akron College of Nursing and her master of science in nursing from Xavier University in Cincinnati. She is a rare gem with extensive experience in both pediatric hematology, oncology, bone marrow transplant, as well as pediatric and adults and gynecology. And she currently serves as the patient navigator for the fertility preservation within the comprehensive fertility care and preservation program at Cincinnati's Children. In this integral patient-centric role, Olivia is a thread that connects all key stakeholders, so patients, family, oncologists, reproductive specialists, and support staff ensuring seamless and compassionate care. Olivia is also the chair of the Patient Navigation Committee within the Global Oncofertility Consortium, as well as a board member on the Patient Navigator Scientific Committee. She's globally recognized for her leadership and advocacy in the oncofertility space, and we are very incredibly fortunate to learn from Olivia's experience in the model of implemented at the Cincinnati Children's. So please join me in welcoming Olivia this morning for a, I hope, very, very interesting presentation for everyone. Thank you.
Oh, thank you so much. Sorry, I thought I was on screen the whole time, but here I am. It's an honor to be here today. Thank you so much, Dr. DeFord, for inviting me. It's been an honor to get to really know you over this past year within this oncofertility setting. So thank you so much. Today, I'm excited to virtually share with you all about kind of building an oncofertility program. I'm going to go over kind of our mature, at this point, programs experience. And it's just so neat to be a part of Fertility Awareness Week at your hospital, which then in turn makes me a part of the Canadian Fertility Awareness Week. So that's just really super special. A little bit too, just to know about me is that, I've been at Cincinnati Children's for over 15 years now, and it's been an honor to be able to have worked on the inpatient side of oncology. I was then able to take an opportunity with pediatric and adolescent gynecology while I was getting my master's, and it all turned out to be such an amazing experience to kind of blend my brain with reproductive knowledge, fertility preservation, as well as pediatric adolescent gynecology and in oncology. So thank you so much for having me. As we get started today, I want to make sure that I do say that I've got nothing to disclose today. This is the front of our hospital at Cincinnati. Some of the objectives today that I'd like to review with you all is really just going over the importance of oncofertility and the impact of cancer therapy, going over the impact of the fertility preservation program, as well as our institutional experience. Just to put things in perspective where you are versus where I am, I love to put things geographically out there, but here I am down here with this little star. So we're not too far, but I am originally from Buffalo, so I would have been even closer to you all, but I moved here when I was very young to Cincinnati, but we're tucked down here in that left lower part of Ohio. Just to give you some more idea about our institution, and I do this too so you all can understand how you can kind of take our story and kind of blend it and how it fits with your own hospitals. But we do serve in multiple satellite locations as well. Our main hospital there is in the center screen, one of our new buildings, which is our critical tower building, which houses all of our bone marrow transplant patients. So I'm up there quite often. But we also serve a really unique area in which we have 3 states that kind of all come together here: Ohio, Indiana, and Kentucky. We see patients from all over the world, but we primarily serve patients within that region. Other things just to know about our institution is that we are a big tertiary care referral center. So it's been interesting in evolving this fertility preservation program as we've had to grow with the outreach of our entire hospital. We also work closely with the University of Cincinnati, and that's been very instrumental in working with them and the fact that we do not have andrology labs on site. So really partnering with your reproductive endocrinology and fertility teams that are local. You guys have a unique gem with Dr. DeFore and all of her amazing training. So we don't have that person here who is able to do both things. So it's really important that you do find your friends within your academic adult hospitals who can help. We also wanted to share that's been exciting that we have been ranked #1 in cancer care within the US News and World Report. It's been such an amazing journey to see the influx of patients coming from around the world and also being able to meet the needs of their fertility preservation desires as well. So just a little bit more, when we're thinking about building these programs, we always want to understand exactly, what's your volume? What's that denominator? And so it's been really great to understand that, for our patients over the past couple of years that are coming to our Cancer and Blood Disease Institute, we're seeing over about 600 new visits per year. And so as we started to build our program, we knew we weren't going to be able to go tackle all these patients at once. And so how could we go and understand little by little, maybe what subspecialties within CBDI we could first see? So these are some of our units that you could see as well that we have within our institution. But let's talk about now just kind of the whole epidemiology of childhood cancer. I think it's important to understand that childhood cancer represents less than 1% of new cancer diagnoses in the US each year. Childhood cancer is not rare, and over 15,000 children are diagnosed each year. 43 are diagnosed every single day, and over 40,000 children are in treatment every year. Average age is around 6. This is a good overview of what pediatric cancers are most prevalent. And so you can see that most prevalent right now, we can see are the leukemia patients, about 25%. I think it's also important that we understand cancerhood generalizations. Cancer grows super fast, as we know. Some will spread quickly. There can be minimal time between presentation and diagnosis and therapy, which becomes really important to understand that with certain diseases when we're talking about finding opportunities for fertility preservation. They respond well to traditional cytotoxic chemotherapies. We know that's specific for dividing cells. And they act at the DNA damage or DNA repair mechanisms, which again, super important for understanding what fertility preservation options you can utilize when a patient may be on therapy. We know that we're entering a new era of immunotherapies, targeted therapies, response-adapted therapies. I'm not going to go into all of that today for this presentation, but I think it's important for us to understand that we're going to be seeing more new innovative therapies that we might just not quite understand the reproductive effects in the future. But the late effects we also know are extremely common, and that's what I really want to speak about today with regards to gonatotoxicity. Cumulative dose of the chemotherapy is of utmost importance in understanding those late effects. So let's talk about the future fertility and how this has been proven and said to be very important to our patients and families. And so we know that infertility consistently ranks one of the top concerns. I see it here even when I go to my own survivorship clinics where I get to go and meet with these families on the other side of things when they maybe didn't have that fertility consult in the beginning of their treatment. Majority of adolescents, 66 to 100% desire information. I think information is key. Whether we decide to do something or not, that is the patient's decision, but just that information is so important and knowing that they want that. And we know that 75% of childless cancer survivors want future children. And so we know that survivors are placing a great value on parenthood. And I thought it was interesting too to see that men who sperm banked felt that it helped them cope with cancer. Discussing these infertility and fertility preservation options at the time of diagnosis have also been shown that we can absolutely take that and be able to have some more hope for the future as well. So effects of cancer-related infertility on the quality of life. We know that there's unfulfilled desire to have children who are associated potentially with worse mental health and quality of life in cancer survivors. Discussing these risks of infertility and fertility preservation options at the time of diagnosis can absolutely relieve stress. It's so fascinating now to see families like coming in and actually asking us, even to the oncologist, can we talk about this fertility? Back when I started, no one had a clue that I was even talking to their child in their arms half the time about fertility preservation. These parents would be like, oh, I'm actually okay, I don't want any more kids. I'm like, no, I'm talking about the patient. And so we also, as I stated earlier, about men who had also found it better to cope. And we know that our experts agree that having these conversations are super important. And so we look out to ASCO, ASRM, AFON, and we know now that these statements have come out that it is absolutely imperative that these patients get that referral to the appropriate practice. So even if your institution right now may not have a plethora or even one fertility preservation option, that referral is going to be important. Because again, whether or not patients decide to do anything, it's that conversation and that point of saying, we need to sit down and take that moment. So who is at risk? We know when we think about when we're saying risk assessment, gonatotoxic risk assessment, what does it say? And we're basically saying for females that the risk of premature ovarian insufficiency prior to the age 40 is based on population statistics. And for males, the risk of permanent algospermia or azospermia following therapy based on population studies. So it's not perfect. And I'm going to talk a little bit more about risk assessment. It's not an estimate of acute premature ovarian insufficiency. It doesn't assess other factors related to infertility. So as we can say, when we're doing fertility consults, we can never predict anybody's future fertility, but we can sure understand what the treatment could mean in terms of risk. Risk variables are always going to be dependent on gender, age, and therapy, that cumulative and additive dose. So I know I don't need to go into too much of a lecture on exactly the male reproductive system and the female, but I think it's important to just have a baseline knowledge, because even families need to understand when we're speaking with them. We will have a consult that says, before we get started in explaining to you that risk to the testis, what is the role of the testicles? Why are we even having this conversation? And I think it's important for them to understand that there's two roles. There's the role of hormone and the role of fertility. And so knowing that there's two layers of the cells, the chemotherapy is going to cause less of a hindrance to the Leydig versus the Sertoli. So once the Sertoli gets affected and you can't replenish the layer, we know that the patients then could have, that risk of azospermia. But I think it's so important to know that you can have infertility without testosterone deficiency. In fact, we see it a lot here, and that can be common. So in survivorship, we do always encourage semen analysis. For females, I like to tell our families and our patients that us women are born with all of our eggs. We know we're born with hundreds and thousands, if not million. But for all women, our fertility timeline, regardless of treatment or seeing any types of gonatotoxicity, your fertility timeline will decrease. And you see that dip around your upper 30s, hit 40s. And so it's really trying to understand for our patients that not only do we have that role of fertility, but hormone. And so can we fix hormone later on if we find out that the actual ovaries have been affected? Absolutely. But unfortunately, I have to explain that there is no magic pill, patch, or injection to give you back your immature follicles. And so that is why it's of utmost importance to talk about that fertility piece before treatment starts versus hormonal continued follow-up later on. And so the treatments that we're all seeing now at our institutions for treating oncologic malignancies, blood disorders, we're seeing chemotherapy, surgery, we're seeing biologics, as well as radiation. I could go off about each of these for a long time, and for the sake of time, I'm just going to focus a little bit more on the alkylating agents, because this is the one thing we absolutely do know more about. We know that alkylating agents have that resting cycle specific mechanism of action. Cell death is via single and double-stranded DNA when it breaks, and it can affect those rapidly dividing cells and those quiet cells, right? And so we know that not all alkylating agents are the same, though. And so I'm going to go into a little bit more about risk assessments later on. But the most important thing that we can say in the literature is that we can look at our cyclophosphamide equivalent dosing. Cyclophosphamide has been well established. We know that now we've got tools from the Oncofertility Consortium kind of initiatives that they have built standardized risk assessments. You can also convert the alkylating agents to cyclophosphamide units. There's online resources where you can look at the calculator. It can actually convert your iPhos right into a CED and other alkylating agents. So we utilize these tools to help us right now. We can use these tools, especially because they just came out not long ago, but all of these articles, which I'll reference again later, can help you actually look at your exact treatment protocol and how gonatotoxic that risk is. So these articles are out there, they're fantastic, and there's more to come. So let's talk about our program and how we took all this information and tried to put it into practice here at Cincinnati Children's. And so back in 2009, before my time in the fertility preservation program, this started with two physicians who were absolutely passionate about doing this. Those two physicians, one was a pediatric gynecologist and one was an oncologist. They really wanted to figure out how we can make this fertility preservation program be more, have more continuity of care and make sure that everybody across the board was trying to get a consult. But with two people, that was going to be no easy feat. So they tried to incorporate some of the floor RNs and nurse practitioners, but it was just not very cohesive in the fact that everybody was having this conversation. And it became very limited to mostly young men who could sperm bank. There was really no established relationship with our local REIs, and we had a really difficult time back then to get buy-in from oncology. We also found there was confusion that the one main oncologist who really wanted to build this program, when she was delivering her new oncology treatment plans, new patient visits, they were completely forgetting that fertility part from what she was saying. They would actually say that they don't even remember her talking about that. So we really wanted to figure out a way that we could kind of pull that consult out from the main oncologist and have a separate conversation that might resonate just a little bit differently versus all the long-term side effects in one sitting. So we've wanted to figure out how we could get a baseline of just who are all the patients coming in, because we think we're seeing some of them, maybe most of them, but we truly found out we weren't. So we were able to utilize some quality improvement projects, coordinators that we had here in the institution back in about 2011-12, and we were able to regroup. The 2013 regroup is really when things started to take off. We wanted to start bringing in more people and get more buy-in across the Cancer and Blood Disease Institute. We, in 2014, tried to find leads within oncology, pediatric adolescent gynecology, pediatric urology, and the role of the patient navigator, which is myself, was starting to be developed. We also tried to kind of reach for the stars and start having conversations with pathology, ethicists, research coordinators, and even get a program coordinator. This all took time and did not all happen in 2014, but we really knew we needed more of a multidisciplinary approach. We also thought about how could we reassign roles. Before, basically, we had an oncologist take a week of fertility consults call, and then the gynecologist. And we realized again that we needed to kind of take that out of the picture, the actual oncologist giving the consult. So we had found that if we could find a process that would allow for the navigator to intake all of the fertility consult order sets and referrals, we could then streamline it to the pediatric gynecologist to do the females and the urology team to do the males. We continue to formalize our relationship with UC and have them, which is our University of Cincinnati group, really understand about the patient volume that we were lacking and how we wanted to increase those numbers with them, as well as understand more about timing for egg freezing. I think we were really lacking on understanding that they could get those done even faster than 3 weeks for our patients. We started to bring TTC, testicular tissue cryopreservation, to our institution, as well as ovarian tissue cryopreservation. But before we were able to get started, we found that when we were going through charts to understand who deserved or who should have a fertility consult, we needed to have an operational definition. So our definition, we had to become very clear and who would not be appropriate. And this helped a lot with the oncology and the bone marrow transplant buy-in and understanding that we weren't just going to walk into any room and start talking about the hope of fertility in the future without really reaching out to say, let's come up with exclusion criteria. Our goal overall was that we would see 90% of any patient within the Cancer and Blood Disease Institute, regardless of their risk. So whether they were minimal risk of having gonatotoxicity, significant or high, they all would still get a conversation. The exclusion criteria we came up with as a team included surgery-only patients, observation-only, palliative patients, people who have come with a previous fertility consult who didn't change when we started treatment here, or the family had the right to just decline it, which actually really, I have to say, rarely happens that we have a family say no thank you. So once we came up with our definition, we did a quick retrospective chart review. This chart is very old, but I think it just speaks volumes in understanding the history of our team. We basically were able to track how many patients we were seeing with this old archaic Excel spreadsheet that I used to keep. And some people ask, how did you know, what charts to even look at? So I reached out to the oncology registry team. They have to report all of the patients and diagnoses, typically to the state of Ohio. And so I found that those would be my best people to gather a denominator. And then I would go through to see who actually did get a consult. And as you can see, we were really kind of dipping way back in the beginning each month of the program, trying to figure out how are we missing people. And we did find that having a navigator absolutely increased this time. My role was not to be hired in gynecology to do this, but I slowly chipped away asking for hours to work on this. And as they could see, when I would have more time, our consult rates would increase based on being able to have that integral coordinator in the middle who could identify patients and kind of send off who needed to go see them. The impact of the fertility consult team. We knew it was going to be super important to continue to keep building our team over time. And as we were able to have members from other disciplines, we found that they also had a great interest in certain subspecialties within their division. So in oncology, I was able to have Dr. Karen Burns take on the role of writing all the risk assessments for our patients. Dr. Myers was super passionate with her bone marrow transplant patients. So she was our liaison for bone marrow transplant. And Dr. Christine Phillips would help us fill in whenever Dr. Karen Burns was on service to take on the risk assessments. We eventually got pediatric urology involved, and they have been great in helping us see all of the male patients. So whether it's sperm banking, testicular tissue, they're also the surgeons who do the testicular tissue cryopreservations here. And then in pediatric and adolescent gynecology, Dr. Leslie Breach is our division head, and her and my other attendings will rotate who takes on the ovarian tissue cryopreservation cases. So to talk about the role of the navigator and kind of how we all make this work. So my role right now is to make sure that I'm educating, assisting patients with the medical diagnosis or treatment that places them at risk of fertility complications. We do this at best prior to the start of gonatotoxic therapy. But as our institution has grown and become a really big referral center, I don't always have the honor in meeting patients right at the beginning. They might come to me on treatment. So then it's also trying to figure out exactly what they had seen prior to coming to us. But being the main point of contact between HEMOC and gynecology, general surgery, the way I was able to really build those relationships was really showing up at multiple meetings throughout the week. So I would make sure to go to tumor boards, all of the liquid lymphoma meetings, bone marrow transplant care coordination meetings. And we basically even set up multidisciplinary times where we would come together as a fertility program once a month. And we still do that, where we all make an hour to come together from all of our busy schedules and talk about the team, our goals, and how we're doing. And so it's been a role too that I've been able to now in my career see people before, during, and after into survivorship. So we keep the continuum going, and they have that face that they can recognize, as well as my partner, Caitlin, who works alongside with me, to have us as that main center of contact to hopefully we can achieve the most seamless care for these patients and families during such a critical time. So I jokingly call myself the glue, but it's not just myself that's pulling this place together. It's really just having that main point of contact that everybody can reach out to really kind of take that care and streamline it into one main point, where whether we are reaching out to REI that my patient needs to egg freeze in the next 3 weeks, or I need to get a sperm banking emergency in the next 24 hours, or I need to get my patient to the OR to remove an ovary before starting her bone marrow transplant. All that care coordination has been really great when I've been just building so many relationships with these teams inside the hospital. So just to give you a look on how a patient referral would come in. So if a new patient is referred to us through BMT or oncology, the primary team can get a hold of us through a couple different ways. And so once we get that order, we can assess to see just how acute is that patient. The one thing we learned very early on was that you cannot have the same modality to reach out to the fertility team in each program within your Cancer and Blood Disease Institute. We all understand that different cancer diagnoses are going to work in different ways when it comes to the process of working them up. So we found quickly that if I have an inpatient order set for every new oncology patient, that might be way too late for a patient with maybe a Ewing sarcoma that's coming in that's actually been outpatient for weeks trying to wait for pathology. I could have been meeting with them weeks ago, but if the order set goes off inpatient, I most likely lost opportunity for fertility preservation prior to treatment. And so we had to really work with the teams to figure out how can we make this as easy as possible for you all to remember to reach out to us and to do less work and put it on us as a fertility team. And so we met with each of these teams and we really found out that we have to have different ways for them to reach out to us. And so each team is unique. And we also knew that we could not just have one standard hard stop within our EMR. And so we built a couple different ways. Some of these might seem archaic where you're like, wow, a desk phone, really? But yes, I did not have a desk phone. And so that was a big deal to have my own phone that people could get a hold of me before all of these like apps on our cell phones showed up. But we built a fertility console at cchmc.org. That fertility email really took this away from having this go to like one personal email that can constantly be checked and be sent from that box when you're dealing with referrals from other hospitals, when I'm dealing with the inpatient team, and then my coworker and I both have access to it. We also knew that the inpatient order set, as I stated, wasn't going to work for all. It's fantastic for our leukemias, even some of our lymphomas who are coming in through the ED, get admitted, but we needed an ambulatory order set. So we also created that. Those orders can actually then, when they go off and they're put in Epic, will go to this fertility consult box. We also still have a pager. I'm just like laughing at all of these old school things I have. So I carry a pager still, the desk phone, and then we have a website, and that's fantastic for like web inquiries that we get from other patients and families. But this is an example of some of the order sets that we utilize. And so what happens is when an order is placed, then Caitlin or myself will get a list of orders in Epic, and it goes straight to our own personal basket. And then we can figure out who is most acute. So for example, if I get multiple orders in one day, I really want to think about who is the patient, the age, what is the potential diagnosis? Half the time we don't know the diagnosis, and who would be of most acute that morning to go see, or who can I plan out to go see in the next couple of days, weeks, or months? For example, elective transplant, sickle cell, beta thalassemia, we might have some time to put them in a clinic spot. But for example, this patient, the 16-year-old, would probably be the quickest one I want to go run to see if they could sperm bank. And so this is kind of the checklist of how we would go through these orders. So once I figure out the patient, the age, where they are, what they're going to potentially be given, that is where we want to come up with our risk assessment. And that, as I mentioned, Dr. Karen Burns has been our primary point of contact for obtaining the risk assessment. In other hospitals, many people might write these and figure it out. But we've just polished this process so that we have the same person writing each one. And then regardless of who does the consult, they copy and paste her risk assessment into that fertility consult note. So when we look at risk assessments, we're going to go back to these charts because I highly recommend that everybody starts utilizing these, especially for that pediatric COG protocols. But what you'll find within all of those articles are the gonatotoxicity risk stratification. This one is specific to females, and I want to draw attention here to the alkylators. The difference between the women that we must understand is that there is a big change when you have a prepubertal patient versus pubertal. And as you can see, for your prepubertal female, it takes more cyclophosphoequivalent dosing to cause the higher level of increased risk. As we go down this chart, you'll see that we do have a heavy metal category. All of our bone marrow transplant, regardless if it's myeloablative, reduced intensity, we have found them all to be high, and that has now been published. And then obviously radiation exposure as well. For males, it's a little more cut and dry. We have seen now that regardless of being pubertal or prepubertal, it takes greater than 4 grams of your cyclophosphamide equivalent dosing calculation to place our patients at a high level of increased risk. We really only see on this risk stratification significant falls in these heavy metal category. So you'll see some of the patients over here who are getting a lot of like cisplatin fall into that. But typically with males, it's pretty cut and dry that they're either minimal or they're high. As well, you can continue and just really wanting to give attention to these top categories. When we meet with our patients, we also then bring that risk assessment with us. And so, for example, this is how a risk assessment might be written at our institution. We have an 18-year-old female, we'll put her initials in there with a newly diagnosed Ewing sarcoma. She will undergo therapy as per AEW S0031. This protocol contains Cytoxan, ifosfamide. The set is approximately 4.5 grams per millimeter square, which places her at a high increased risk of infertility as a result of this therapy. So for then the navigator, my role would be to then reach out to the primary oncologist when I understand her risk to say, do we have time to egg freeze? And if not, would you be comfortable in us offering ovarian tissue cryopreservation? Once we get that information, I can sit down with her and present the opportunities. I then take my infertility risk meter that we have developed here through our awesome partners. We at University of Cincinnati's college, there's a design and art school, and there's students who are always looking for projects, and they actually were able to kind of build our dream of making these risk assessment tools for us. And so they built these, and it's great. They're cardstock and they're paper, and they're actually on our folders too. And I can bring them in the rooms and just click and check off where they fall, take notes. And it's just a great visual for them to understand where they fall. So we bring our risk meters as well. And then they also made us these shared decision-making cards. So for the purpose of the 18-year-old patient, I would have obviously sat down and gone through, if I got the permission from the oncologist about ovarian tissue freezing or egg freezing or embryo, we would go through that. I am not going to go over all of these fertility preservation options in this presentation because I really wanted to showcase how you can pull this all together. I know there's a lot more exciting lectures coming your way this week, and you're going to learn more about ovarian tissue freezing. But for our institution, we do offer OTC. We offer it as young as 1 day old up into however old the patient might be that may not be able to elect to do egg freezing. We have done that over 200 times, and I'll show you at our institution, and I'm happy to share some of that data with you towards the end of the presentation. We do offer testicular tissue cryopreservation here. I will say that's still on a research study, so our IRB had to approve it institutionally. We got the study from UPMC, which is where Dr. Kyle Orwig started this study. It is still research in the fact that it has not yet been proven to work on humans. But there is currently now a person who has put their testicular tissue back in their body after going through treatment. And we are waiting to see if that tissue does end up being able to achieve reducing sperm. But for right now, it is research. We only offer it on patients 0 to 25 years old, and they have to be at high increased risk. Our ovarian tissue cryopreservation, I should have stated, is considered now standard of care. We do not have it under IRB. There is opportunity for patients to elect to do that regardless of their risk. But of course, we are going to be, we find it more appropriate to offer those patients who fall into that upper significant high risk to do that. Sperm banking, we work again with our partners in our andrology lab with UC. And we do that probably over about 20 times a year as well for our patients. So once we get the risk assessment back, this then goes to the navigator and then the consult is deployed. And based on timing, availability, and acuity, it might be myself running to see a consult. I do not bill personally myself. And so there are many different models for the navigator. Some people have a nurse practitioner doing this who can bill. We have an NP on our team who might see patients as well and bill. But at the end of the day, we are more worried about getting into those rooms quickly to give the education that might in turn turn to a fertility preservation option. And if it doesn't, that's absolutely fine too. Once our consults are completed, we are all about making sure we are constantly tracking our data and looking at quality improvement. And we have finally moved off of my archaic Excel spreadsheet and have a red cap. And so this is one of the flow sheets. Everything that you see with that arrow, like the little squiggle lines, has drop down logic. I wasn't able to screenshot everything for you all, but this has been super great in tracking our progress and the patients. We put a flow sheet on everybody, and then we're hoping this will help with the research too. So as we began to really streamline our consult process, we knew we had to keep learning, as seen from that chart earlier on, that we may have had dips in our data. And sometimes it was, we just have to build a stronger program. Or sometimes it was, oh my gosh, we built a proton program and we had no idea how many patients that we were seeing getting proton that never came through the fertility program desk. And then I had to go out there and meet with the proton team. So I think this data is just imperative as programs keep changing and growing and new therapies come. There's going to be different things that we're just not always going to catch. But the one thing we did learn was that when we do consult internal patients, we saw a huge dip in our data. And I always like to share this story because we were missing patients who we thought were going to be minimal risk, but then they ended up needing a bone marrow transplant. And this was a lot, of course, for our leukemia patients. And by the time we would realize that we didn't see them, it was too late. They had already received their myeloablative prep regimen. So we had found that even if a patient had a fertility consult within the Cancer and Blood Disease Institute, we had to start understanding when a new treatment plan was being uploaded or they're going to a different service within CBDI that warranted another fertility consult. So many of our patients might see us 2 times, maybe even 3. Another example might be a Wilms tumor patient. If the patient has to escalate to like regimen M, we missed one of those one time too. And we're like, what? Hold on here. And it was actually the family that brought it up and said, Olivia said, if we change protocols, she has to, you got to get a hold of her. And they elected TTC. So there's many nuances within even a team that is slowly building that we have learned that we really want to help other programs understand that you don't have to go through all the hurdles, all the barriers, and all these learning points. Because we have been there, we have done it. What you're seeing has been over a decade in the making. And so we just keep evolving. And so what we learned too was that when patients did go from one team to the next, we would have the inpatient care managers help us to identify on their new patient checklist that they would have to check off that they had a consult on that service. And so really kind of looking to either your patients, whether they have like a primary nurse practitioner, we have primary care managers. I know that's very unique to our hospital, but it's a nurse that really follows them throughout their whole journey of their whole diagnosis, looking to those people that are like constantly laying eyes on those patients. And then we also wanted to figure out how can we maintain this process for outside referral. So we're growing, we're getting bigger, and then people are finding out, well, you guys are the only ones offering ovarian tissue cryopreservation within a 5 or 6 hour radius. Can we just come to you for ovarian tissue cryo? or testicular tissue cryopreservation. And so we had to kind of lean back into the team to say, how can we do this? We have to then be okay with our anesthesia team seeing outside patients, general surgery, get scheduling, but we also need to make sure that they're in a great, healthy place coming here, right? And so we determined that for patients coming from outside referrals, we wanted them to be in the most stable spot they could be before going into their transplants, before going into their chemo. And so for patients who come here strictly for standalone OTC or TTC, we might ask them, hey, if you needed something else under anesthesia, like a port or a line, do you want us to combine it? If so, we're happy to do that here. If not, no problem. Let's just make sure again that you're reaching some of our criteria. So we talked about ANCs. We want them over 750. Our BMT patients do have about 5 to 7 days of healing after their fertility preservation before they would start their prep regimen. We knew that we were getting a lot of sickle cell patients coming to us from other institutions. We worked with hematology to build a hydration protocol and same-day surgery so that they would be able to not have to do an overnight and potentially have to deal with more cost. And then making sure transfusions, that everything is done and complete before they come to us. So they're strictly coming here for that preservation. They can stay local that night and then head home the next day. We know that Rome was not built in a day, and I have to say that I am a part Italian, but this has all taken time, and it has taken small chunks each and every day that we have to figure this out. So I wanted to share with you just kind of some high level bird's eye view of the program and how we have been able to identify our strengths and our weaknesses. And so as you can see here, I put together some charts to just really show you how many misses we would start with back in the beginning of this program. And as I stated, I went to our oncology bone marrow transplant kind of registration, the keeper of all numbers, to be able to do chart reviews to figure out, did we see these patients? And you can see that we had a lot of misses in the beginning. And so we also then realized that some people we want to call and try and get a hold of us, they might not want to. Some people might actively say no, thank you. But we would hone in on these misses to figure out, what did we do? What could we do better? How did this get missed? Was it not having a great way for us for them to get a hold of us? So it was in like 2014 that we realized, oh my goodness, our inpatient order set was working, but we were missing all the outside patients. And just to kind of look at our definition. So when I said we might have over 600 patients presenting to the Cancer and Blood Disease Institute within a year, only about half of those patients really fell within our definition of needing a fertility consult. So that kind of, take a deep breath of, oh my gosh. So half of those were follow-ups only, surgery only, palliative. They may have already had a consult. And so then we would break it down to then how many we did end up seeing that were eligible. Just to kind of give you an understanding of what patients are electing here. So we have ovarian tissue cryopreservation in the pink, testicular tissue in the blue. I shouldn't have picked blue again, a light blue for sperm banking, and oocyte. You can see that oocyte cryopreservation has been something that has been we have not been able to have a lot of patients elect to do it. So we've actually been working hard with our REI to drop the age of which they're comfortable in doing this. And I think this is going to change moving forward. We had a pretty hard stop at 16. And so we are now going to be dropping our age to about 14. We also have had more conversations with oncology and kind of their hesitation as to why they don't feel as always comfortable with allowing their patients to do that. But I already this past year have had a couple girls do it. And so we'll see how this changes over time. Looking at the teams, so I think it's interesting to break this down too, to understand what teams were referring to us the most over time. And you can see that solid tumor has absolutely been one of our here at our institutions, has just more quantity of patients. And one thing that I think tracking is just so important. I think that overall, we have continued to talk about how at our institution, we find it just imperative that all families are having this consult. whether they're low risk, significant, or high. I don't think that anybody here is like patting ourselves on the back for doing so many ovarian tissue cryopreservations. We just get, our buckets are filled in knowing that our families are all having this conversation. When we first started the program, we found that if you would only go talk to maybe the high risk families, then we knew it's not fair because a risk is a risk, right? So even low risk, they're at risk. And so families talk, they don't understand why you went and talked to room 38 and not to room 42 about fertility and why it was, something to think about for the future. If someone's getting treatment and it's appropriate and they're not palliative, we need to be talking to everybody. And a risk is a risk. And so our biggest thing has always been conversations. Everybody deserves that education around that risk, whether they choose to do something or not, completely up to them. But when we did look at our patients who hit that high risk, half of our patients are choosing to do something. I thought that was actually really interesting to see. But overall, again, those conversations and being on the other end of things in that survivorship clinic and having those conversations that even though you were minimal risk, we have seen a big dip in your AMH, and I do want to send you to REI to talk about egg freezing. We're seeing that as well. So just really having that seamless care amongst everyone and having that conversation has really, I think, is what set us apart. There's so many great articles too out there about that the Oncofertility team has put the Oncofertility Consortium program has put together. It's been an honor to be chair of the board and really get the minds together of why these programs are just super important and being on the front lines of patients and their reproductive health. I wanted to save at least 15 minutes for questions, so I ran a little over, but here's my contact information if you guys have any questions, concerns, as well as our website. And I can send that to you all as well. And yeah, I'd like to open this up for questions now. Thank you so much.
Thank you so much, Olivia, for sharing. I'll just wait and see if anyone has questions. Otherwise, I have a few, as you may expect. Well, I'll get started. So our program is not at the same maturity level as yours in Cincinnati. Do you have any pearls in terms of things we should definitely do to move forward or avoid doing mistakes that you've made that we should avoid to fast track or moving forward with the program?
Yeah, so I think my biggest thing was I always preached one thing we did right was start small. So we have our liquid lymphoma program, our neuro-onc program, our solid tumor program, and bone marrow transplant. Dr. Karen Burns, who has been one of the 2009 passionate attendings that sat with another doctor at the table and was like, we have to do this. She's like, well, I'm a leukemia lymphoma doctor by trade. So let's start with my program because they're going to have to listen to me talk at meetings. So she wanted us to start with her group because she's like, I already know these people. They have to deal with me. Let's trial it there. And so we started small. We trialed out me going to their meetings, hearing about who was maybe admitted, who was coming through the ED, and then we started that inpatient border set. So I think that was super great because then we jumped to the next group. I think we did solid tumor. And I was like, how are we missing so many patients? Like they're already starting chemo, it's too late. We built the outpatient order set, right? So start with a team because you want to feel good about getting the job done too, right? If you go big, there's no way. I think if you think about the patients who are most at risk, bone marrow transplant, right? We have a pretty big transplant program. We transplant about 10 to 12 kids a month. Those are the most at risk. So would I say like start there? Probably. But whoever is your like cheerleader in that group, like whoever they're on service with, go there because that's a great way to have that. All right, let's bring up fertility today. And they'll be like, what? Yeah, we're going to talk about it every meeting. Things I wish we would have done sooner was possibly like pull REI into our like monthly meetings that we have at Cincinnati Children's, even though that physician is at UC, the University of Cincinnati. I wish we would have had them like come to that monthly meeting earlier on and had them feel more a part of the program. I think it's super important to have that relationship, because when you have that, they're more eager to get a navigator over there. And when you have an UC, like an REI navigator, oh my gosh, all like we have to get a lot of philanthropic funds for medications. I know your healthcare system is very different, but for someone to advocate to like get the medications, get their calendars, get them moving fast, get the oncologies to sign off that you're okay with this. And then there's sperm banking. I could text her now that I know her so well. I need an appointment tomorrow morning. Please, like, I know your lab's closed. Can you put this in your computer system? I can't do that over here. So just, again, you're their secret gem, Dr. DeFore. You've got the N with the R's.
We have comments in the chat. Everyone's very grateful for your presentation. I think one thing that we'll need to work on is also relying on Epic and using Epic as you did to track the changes and see how things are going. So if our Epic leads are interested, I think that's definitely something that we'll need to work on.
Yes, and that was one thing that I felt oncologists and bone marrow transplant were very happy and eager to be like, okay, if I don't have to have this conversation, like I'm actually already kind of not doing it. Like it's like my biggest thing. It's like, we can't just like glaze over this when we know that there could be a fertility option to do, and knowing what survivors are saying now and how important this is. So when we kind of took it out of their hands to say, our team will sit down and do that separate consult, what is the best way we can get a hold of you? And they were like, oh, wow, if I just like click this button in Epic, easy peasy, I'll just say in rounds that the fertility team's coming. Or my first outpatient visit, when they go through the checklist, you're going to have an, GFR, you're going to have a PET, you're going to have a fertility consult, you're going to meet with behavioral medicine. We just are a part of that language, and it's turned into, it's normal, it's natural, right? It took years for that to become natural, but that's where we're at.
Yeah. Tanya, I think you have a question.
Yes, thank you so much for sharing all that this morning. And I think the key message is that low risk is not no risk. And I think that's an important message to share with all. But my question for you is, for your patients that are doing oocyte cryopreservation, is that being done in your children's hospital, like under sedation or general anesthetic, or is that being done in a fertility center? Can you expand on that a little bit?
Yes, so currently it is done at the fertility center. We do have the patients go under a light anesthetic there. They do utilize that. We have just now recently, we're in the depths of conversation with one of our REIs who is so passionate about oncofertility, Dr. Hurley. She was actually trying to figure out, could she get privileges to go to our hospital, retrieve the oocytes under anesthesia, bring the incubator, and then like hurry it basically across the street. Our Liberty campus is really close to their andrology lab. So we're having some communication about that. But right now, they do have to go to the REI to have that done under sedation. Everything is done there.
And just to, get two clarifications, is it being done transvaginally or transabdominally? And is the sedation done by an anesthesia if they need more, or it's really done by the REI?
It's done by the REI, and they have anesthesia like on site there. They were concerned that their anesthesia people would say like, we don't want to do pediatric patients or younger patients. And then I'm like, okay, I'm not sure how like the 14-year-old with the BMI of like 40 is different. But anyways, basically we got it down to their anesthesia team is willing to go as low as 14. I think that was the reason that was holding us from going below 16. But we do this right now transvaginally. We were looking at doing some transabdominal protocols, again, working with REI in that right now, due to just some of our patients with just some cultural differences that they don't want to have anything done through the vagina. We are not there yet. I know there's other hospitals doing them that way, but we are not at our REI doing it that way right now.
Thank you so much for sharing that.
Of course. Looks like Eva has a question.
Thank you so much for this talk. I'm not an oncologist, I'm not a gynecologist, but just out of curiosity, and this may be a very obvious question, what is that process of like the sperm banking and the oocyte preservation for like, do the patients have to pay for it, or and then what happens if they do end up passing away? What ends up happening to those tissue samples? This is just out of curiosity.
Yes, no, that is a great question. So I will kind of speak on behalf of how we have to do the storage paperwork for each of these things. So whether you are removing ovarian tissue, sperm, oocyte, depending on where the tissue is stored, we utilize a company called Reprotech here in the US. They are fantastic in storing reproductive tissues, been going on for 25 plus years. And so we've got a great relationship with them. And we did say that, you know, we need to make sure that we're all aligned with, if someone is below the age of 18, what are we doing if that patient were to pass? We have had multiple patients pass who've frozen their ovarian tissue. And so within the Reprotech paperwork, for someone who is below 18, that tissue for ovarian tissue either has to go to research or get discarded. You cannot give that ovarian tissue for posthumous relationships, anything like that. It cannot go to anybody. For sperm and oocyte at UC, they have also stated that over 18, you could give it to somebody else, but they have also aligned with, we're going to discard it or give to research. So when I consult patients and families, and I know they want to do something, I always say, I want to prepare you for a difficult section of that paperwork that will be coming your way. And I use the example as, if I'm driving home today and I get in a car accident and I have frozen embryos or eggs, my husband, because I do have a husband, would have to know what to do with it. And so I try to put it in a context of just not such a like grim, oh my gosh, why are you saying you think my kid's going to pass? Why are we even doing this? I would say this is a standard conversation for anybody, whether it is for pick couple struggle with infertility, social freezing, we all have to know that. And so then when they get to the Reprotech paperwork, they've already decided in their mind what they want to do. Cost is a very big loaded question. I don't know how many hours you guys have, but just to make it short, some insurance companies are covering fertility preservation. We have been super doing great with fertility coverage for ovarian tissue cryopreservation with insurance. We do not have a state mandate in Ohio for fertility preservation. I'm currently working on the Alliance of Fertility Preservation to like work on some legislation. As you know, in the US, every state has to have their own mini government, I guess. I don't know. So we have multiple states, I think 17 have the mandate passed. The actual medications to freeze eggs, there are so many philanthropic opportunities that we can get those typically covered. That's about $6,000 to $8,000. We use like the Walgreens Foundation, Heartbeat, Livestrong, but we do have, I mean, it's expensive for just the actual ultrasound labs, eggs. I mean, I think we try to get like an oncology bundle, but it's still around probably $6,000 to freeze your eggs. Sperm banking costs, we have a piggy bank here that we try to like give some money to because insurance will not cover sperm banking. I've never had it covered, not once. So for our patients who are like, you got a sperm bank tomorrow morning in 12 hours, you need $200. That's very hard. So we try and cover those acute quick costs. And then to offset for the females, we do their storage fees.
Maybe I can speak to
Thank you.
there are a few differences. So egg freeze, sperm freeze is covered for us for oncology patients. They have to pay for storage fees. And then in terms of medication, we're able to get compassionate coverage most of the time as well. So if you send patients over, there's a good chunk of all the cost that is covered. Ding, I think you had a question too.
Hi, Olivia, great job, and thank you for sharing everything.
Thanks.
So just for the non-oncologists on this call here, do you have a program at Cincy for the non-oncological conditions that might require sperm banking, which may represent even a larger population of patients?
Yes, and I'm sorry I didn't like hone in on that for this presentation, but we do see multiple other diagnoses outside of the Cancer and Blood Disease Institute. For example, we have a great relationship with nephrology and rheumatology. So just this week, I saw like 2 young girls who have SLE. They're going to get Cytoxin. We all know it's really tricky because we don't know how much, but we know kind of the maximum amount. Typically when those girls get diagnosed, it's like, we're starting tomorrow. And I'm like, they get their kidney biopsy. And so we recommend on a lot of these patients to get like baseline anti-Müllerian hormone blood tests. And so the best thing we've done over the past couple of years is try to like meet with them once a year. We've met with their Turner's program. We've met with our nephrology program. We've met with each of them to say, listen, this is what we can offer your patients. This is our order set. please reach out to us. So it's not perfect, but I feel like every year I'm learning of some new diagnosis. We're heavily involved with like some of the DSD patients. Urology is really involved with them. So then they'll pull us in. But yes, I try to tell everybody this order set is for anybody in the hospital. Anybody can get a hold of us. Especially that email has been great for those teams too, to reach out to us if they forget. They're like, oh, there's some fertility email we've heard about. And then we saw a lot of our transgender patients too. We mostly send them to REI, but I like to do kind of a soft call about like, this is what what to expect, the pricing, and then I can send them there. But yeah, I would say transgender, nephrology, rheum are our biggest other ones.
All right. Well, it was amazing having you present to us this morning. Hopefully next time we'll be in person.
Yeah.
I'd be remiss if I didn't take a moment on the National Admin Day to thank all the incredible admins who helped organize this session. So huge thanks to Rachel, Shannon, Maritza, and Marissa. So it was a lot of work to get everyone together. Really appreciate Olivia for coming. And hopefully we'll still be in touch and grow our program here.
Yes, thank you all so much. Have a great fertility week and enjoy all the rest of your lectures.
Have a good one. Bye.
Bye.